So an emerging topic in the MPNs is that of looking for targets beyond JAK-STAT pathway. And so one of those candidate pathways has become BCLxL. BCLxL is an interesting pathway that looks to be active in these myeloproliferative cells in both the laboratory and in our patients. And historically, there has been no FDA-approved strategy for targeting BCLxL with several candidate molecules. So my group and I sought to investigate that. First, we had laboratory data preceding our efforts that showed that either targeting the pathway by itself with an oral drug called Navitoclax or in combination with JAK inhibitor Ruxolitinib, that this could overcome JAK resistance and possibly benefit patients. So we took that to phase 1/2 clinical trials with Professor Claire Harrison. She and I showed in a smaller group of patients, 32 patients, safety and clinical efficacy of this combination. So the Navitoclax BCLxL inhibitor with the Ruxolitinib in an add-on strategy. So patients were already on their JAK inhibitor, and then we added in the BCLxL inhibitor. That was published in JCO a couple of years ago. Based on that success, then we took it to a randomized phase 3 trial, a global trial, international phase 3, that I presented those updated results at the EHA meeting. And frankly, it's a positive study. The primary endpoint of the study, which was spleen volume reduction, we call it SVR35 at week 24, was met. Highly statistically significant, 60+% versus only 32% in the control group, which was Ruxolitinib alone plus placebo. Now, the supposition of that is that the historical expectation, approximately 30 to 40% SVR35, was nicely improved, right, by almost 20+ percentage points. However, the key to this program in all combinations is that the symptom burden, the TSS we call it, was not quite statistically significant. So that secondary endpoint was not met. So primary endpoint, spleen, was met, but not the secondary. And so what it means is we need to continue to work on agents in the BCLxL field that do both, that allow patients to decrease their spleen, but also to improve the symptom burden. So there's a number of other candidate BCLxL inhibitors out there, both oral and IV, interestingly. So we and others hope that this starts and expands a brand new field of inquiry, not only for MPN patients, but also for those with higher risk disease, such as post-MPN AML.